Hey, Hannah.
Hey,
Oh, you got it all shared just fine.
we're ready.
You are ready. I just need to find my script now. Uh, let's see. Copy of script. It should be Hannah. Yep.
It says it's already recording. Is that right?
Yeah, she'll cut it off. I don't have
Okay.
the ability. Well, I don't have the ability to switch
Yeah,
it
I
off.
just wanted to make sure you knew.
Yeah, yeah. She'll cut it off when she gets on. So, oh, let's see. There we go.
I don't think anyone would try, but I'm going to write do not disturb on my office door.
Oh, yeah. I think everybody around here knows.
Yeah, just not students.
Yeah. Oh, well, that's true.
I
Yeah.
had one come in yesterday.
Oh, golly. All right. Here we go. Oh, you used the EMU background. That's right.
I did.
Yeah, looks good.
I do have Goshen though, like
Oh, yeah, no. Good.
reference the consortium.
Yes. Vincent said, tell Hannah I miss Mike.
Oh, that's sweet.
Because I said, I'm watching Hannah's DNP defense today.
It's crazy. Like when you think about doing a 3-year program, it
Uh-huh.
feels so long. And then
Uh-huh.
all of a sudden you're like, oh,
Yeah. Yeah.
here we go.
Yeah. We're in the final phase.
We're in the final phase,
Yep. It's all project now.
which has been really fun.
That's it. Good.
I do feel nervous about getting all my hours, but everyone told me it comes.
Yeah, you'll get it. Yeah. And you can count anything even remotely
Hmm.
connected in any
Yeah, I
way.
do have to do a lot of training on some things.
Oh yeah.
So,
Yeah. Yep. Oh yeah, we still have 10 minutes.
no, I told you I didn't want to just sit here, that I couldn't
Yeah,
help.
that's right. Well, you can hide yourself and mute yourself if you want.
No, I'm okay.
Yeah,
Had Kate distract me till 9:30.
till 9:30.
Do you want to hear how my morning was though, or do you need to work?
Oh no, huh? No, go ahead.
So, you know how we went on the cruise and then Judah got really sick and
Yeah.
technically Ellie has a double ear infection. So
Oh,
she was started on amoxicillin.
poor baby.
And this morning, I think Mike just had some of my nervous energy. He spilled it all over the kitchen floor. I
Oh,
was like, Mike.
Mike. Oh, so now you have to get another bottle.
Yeah, I just text someone at my practice and was like, will you please send this in? But we had gone to urgent care, so I don't know
Yeah.
what people do.
Who do that? Yeah.
Like, I guess their PCP would just call it in for
I
you.
guess so. Yeah.
You have to get in contact with them and have to tell them the story.
So
And
yeah.
oy.
Yeah. Oh, mercy. Poor thing.
I was like, I'm supposed to be nervous, not you.
Not you. Yeah. Oh, he's nervous for you. Will he be bopping in to watch?
No.
Oh no.
Are people allowed to?
Sure. Do you want to send it to him? Usually more the final defense, but
I was gonna say, I don't really think I want anyone here.
yeah.
Maybe the final defense, I'll have people come.
Yeah. Yeah. No, Garrett didn't want us like for his either his proposal or his the final
Yeah.
defense.
Yeah.
And now Hannah's final capstone presentation, she did invite us and we even like spoke at the end, like, yeah. We
Aw,
even like said something like, and she like wanted us to like, so
that's really sweet.
yeah.
Isn't that interesting how kids are so different? Like, I feel like that's how Judah and Ellie will be.
Yeah. Garrett didn't, yeah. But Hannah was like, yeah, I want you to come. So, well,
No.
hers was a she could pre-record it or she could do it live and she pre-recorded hers.
Yeah, that
And
would
so it played, with her on the screen, but it was a recording.
okay. That's an interesting way to do
They
it.
gave it a choice. They gave him a choice. Yeah.
That's nice.
Yeah. Yeah. You do anything fun today to celebrate?
I have to do post conference with my OB group,
Uh,
and Kimber and I are doing a health seminar for Church World Service for refugee postpartum moms.
oh,
So we
cool.
have to plan that.
Okay.
But then Mike and I are going to dinner.
Nice. Where are you
Yeah.
going?
I think we're gonna do the Chop House bar side.
Nice.
Yeah, because my parents and kids will go.
Oh, nice. I
Yes.
haven't been there in a long time.
I see either.
You
But I like
used to be able to get at Costco, you could get $100 worth of Chop House gift cards for 80, which
nuh-uh.
was really nice. So we had
Yeah,
we had those, and then you basically get 20% off, and but they don't
right,
have them anymore. So it's like, huh,
right. Bummer.
yeah.
Oh, everyone is just so supportive.
Oh yeah.
Dr. Miller just sent me an email. Everybody is just
Oh,
lovely.
wow. Nice. Realize I think I have the final defense script pulled up, so I just need to tweak it. Because it's like 3 years of hard work. I'm like, no, it's only been 2 years.
Not quite. We're getting there.
Defense of her DMP for the defense of her DMP project proposal.
Oh my.
Yeah, it said final defense.
Hi, Eleanor.
How are you? Good morning.
Good morning.
Morning. Oh, I had speaker view on, and I didn't even see there were other people.
Yeah. We're getting a crew.
We are, yeah. Oh, that's funny. Hey, Jewel, would you go ahead and cut the recording off? Thanks. Well, good morning and welcome. I am Dr. Melody Cash, the Eastern Mennonite University co-director of the Goshen College EMU DNP Consortium. On behalf of Dr. Jewel Yoder, who is the co-director from Goshen College, and the entire DNP faculty, welcome to Hannah Ferguson's defense of her Doctor of Nursing Practice project proposal. Before I introduce Dr. Kathy Rittenhouse, who is serving as Hannah's lead faculty, I have a couple of announcements and reminders. The session is being recorded, as you can tell. We ask that everyone keep yourself muted for the duration of the event, and invite you to keep your video on so there is more of a feeling of community. You will likely want to see the speaker view. To see the speaker view, you go to the top far right of the Zoom screen, and you'll see an option for gallery or speaker view, and you can choose the speaker view. The schedule for the session is that Hannah will have 30 minutes for her presentation. There will be a warning, probably wave/chat at 5 minutes and 1 minute. And then after Hannah's presentation, there is a time for the audience to ask any questions, to engage with Hannah on her topic. And you may either ask the questions verbally, or if you would like to put them in the chat, I will ask your question for you. And then after that question and answer period, we ask that everyone accept the lead faculty, and the two co-directors will log off of the Zoom session, and we'll continue to have a conversation with Hannah. So I will now introduce Dr. Kathy Rittenhouse, who is Hannah's lead faculty member. Dr. Rittenhouse is a board-certified women's health nurse practitioner with over 29 years of experience in that field, in addition to her critical care experience. She is a graduate of this DNP program and has been on faculty at EMU since 2007. So I will now turn things over to Dr. Rittenhouse to introduce Hannah and her team members.
Thank you, Melody. It's a pleasure to introduce Hannah Ferguson as she presents her DNP project proposal, which is titled Enhancing Postpartum Care Through a Structured EMR Checklist. Hannah is also an EMU graduate from the undergraduate program and a graduate of the University of Virginia with her master's and family nurse practitioner. She has been a family nurse practitioner since 2019 and currently works part-time in a local clinic in that capacity. She also teaches at EMU and has taught at EMU since 2022 with expertise and excellence in her teaching for students there. So please, Hannah, we're excited to hear your proposal.
Yeah, thank you so much. Well, I'm excited to share with you all my proposal. And as you all have heard, I'm Hannah Tissue Ferguson. I think many of you know that already, but I just like to start off with that introduction. And I'm really excited to introduce to you my Doctor of Nursing Practice project that is entitled Enhancing Postpartum Care Through a Structured Electronic Medical Record, or EMR, Checklist. So I wanted to give you an overview of what we will be covering today. I can make these slides available to you after the presentation if you don't have them, but if you have access to my paper, I went ahead and correlated the contents with this presentation along with my paper for ease of access and referencing. And before we get started, I thought for clarity's purpose, it was important to give you some definitions. So as I'm talking and proposing this project, you know what I mean. So the first definition I want to provide is postpartum. And we know that postpartum is now being considered the fourth trimester of pregnancy, kind of signifying that the postpartum period is just as important as other trimesters when you're thinking about pregnancy care. And for the purpose of this project, the postpartum period is going to be the first 12 weeks after a person gives birth. When I refer to postpartum care, what I'm referring to is care administered by a healthcare provider during this time. And a healthcare provider can be anyone on the clinical team. It can be MAs, LPNs, RNs, nurse midwives, family nurse practitioners. It's any trained healthcare providers giving care to the postpartum patient. And then when I talk about quality postpartum care, I'm referring to the inclusion of 8 essential components, and these components are informed by guidelines, and I'm going to introduce those to you on the next slide. So these are the 8 essential postpartum components. These are the components that should be included in postpartum care. And these are informed by kind of 2 overarching governing bodies. The first is the American College of Obstetrics and Gynecology, also known as ACOG, and then the Center for Medicare and Medicaid, which is CMS. And just to give you a little bit of extra background, CMS is responsible for the merit-based incentive payment system, also known as MIPS. And so CMS sets the requirements that clinics and healthcare providers are required to meet to be able to submit for quality reimbursement. So these are the 2 governing bodies that inform these postpartum components, and you can see what they are here. Breastfeeding evaluation and education, postpartum depression screening, intimate partner violence, also known as IPV screening, postpartum glucose screening, if indicated. And what that if indicated means is that if someone was a gestational diabetic, they need to have postpartum glucose screening as well. Family planning, tobacco use screening and cessation education, healthy lifestyle and behavioral advice, and then immunization review and update. So as I discuss improving quality of postpartum care, I'm going to be referring to inclusion of these 8 components as well as documentation. So I've already kind of highlighted for you that the postpartum period is considered to be the 4th trimester. And that's to highlight that this is just as important as other pregnancy management. And we know that it's an integral part of pregnancy care. However, what the evidence tells us is that key components are often missing. And when these key components are missing, this impacts the postpartum patient, their family, and then it can even go on to impact the healthcare provider and the clinic from having negative quality reimbursement implications. So in order to highlight this for you, I thought I would discuss just what happens when one of those 8 components are missing and how detrimental this can be. And I want to be clear, I could have talked to you about depression and how if we don't screen for postpartum depression appropriately and identify it, it increases mortality for the patient and delays bonding for the newborn. And studies have shown that it also potentially increases depression rates in partners. I could have talked about gestational diabetes and how 50% of those people will go on to develop type 2 diabetes in their lifetime to kind of highlight the importance of that screening. But I'm going to focus on one of the components right now, and I think when I get to my needs assessment, you'll see why. But what I'm going to tell you about is intimate partner violence, or IPV. So what we know is that IPV should be included in postpartum care. However, evidence, both anecdotal and in the literature, tells us that this screening is not happening. One study found that half of those who ended up reporting IPV weren't even screened for this. And the implications for the postpartum client who was exposed to ongoing abuse was negative physical and then emotional health outcomes, such as development of depression, PTSD, etc. They found that newborns who were exposed to IPV in the postpartum period have risk for developmental delays, decrease in overall health, and then increased morbidity and mortality. And the family system as a whole has then a risk for housing insecurity due to potential financial implications. And what I don't even have listed on here is, again, IPV screening is one of the components that must be included to submit for quality reimbursement. And so when it's not included, healthcare providers, healthcare institutions can't get that reimbursement. So therefore, my clinical question for this project is, does the use of a structured EMR checklist improve coverage of the recommended components and documentation of postpartum care for patients who receive this care before 12 weeks of giving birth? So in order to inform this project, I conducted a review of literature, and you can see this diagram there that kind of walks you through my process. I ended with 22 articles. Keywords are listed there. Inclusion criteria included full text availability, peer review, English language, a published date in the last 10 years, while exclusion criteria were people out of that defined postpartum period, lack of reference to an EMR, and non-generalizable subpopulations. And what this looked like were like parents who were having an extended NICU stay and not receiving traditional postpartum care. So from this review of literature, 3 key themes arose: technology use, disparities in postpartum care, and then priority of screening. So with technology use, what the literature told me was that technology can be integrated into and utilized to enhance postpartum care. This type of technology was based on the EMR, and it included things like mobile applications, telehealth visits, clinical support tools, and templates. What they found was that when technology was utilized well, postpartum care was streamlined and disparities were reduced. And practically, examples of this looked like increasing follow-up, increased recognition of IPV and postpartum depression, and then enhanced postpartum documentation to support quality reimbursement. And you might have heard me say well, and I want to kind of qualify what that well means. Utilizing technology well in this scenario means having a standardized process in your workflow that person to person can utilize and have the same results. The second theme of disparities in postpartum care, the literature was clear that there are disparities in postpartum care. And this is both systemic, like racial and socioeconomic, as well as access disparities, like utilization of postpartum services. And the literature showed that these technologies that I have referenced have the potential to start to mitigate these disparities, primarily through increasing access. And finally, the third theme was priority of screening. So screening is pivotal during the postpartum period, and I would invite you to think back to those 8 essential components. Those 8 essential components that I referenced have a lot to do with screening. Screening for gestational diabetes, screening for postpartum depression, IPV, smoking, right? However, what the literature showed was that screening in the postpartum period is often incomplete and not documented. And so what studies have found is that standardized workflows and even EMR templates can ensure complete documentation. And the example that really highlighted this for me was there was a clinic who had rubella non-immune patients in the postpartum period, and the use of an EMR template led to an increase in vaccination rates among those patients. There were some gaps in the literature, which are important to name. There was no one tool that was studied and said, yes, this is what you should utilize in the postpartum period. There was nothing specifically related to an EMR checklist that I could find, although EMR templates were referenced. And finally, there was no tool studied across different types of clinics. For an example, a family med clinic as well as a prenatal clinic. So to me, this highlights the need for my project, which was also going to be supported by my needs assessment, which I'll share with you. What we know, what the literature tells us, is that technology can improve the quality of postpartum care. And so my question is, as I referred to, is can an EMR checklist do this too? So, as I've said, the purpose of this project is to improve the quality of postpartum care and then potentially incentive-based reimbursement through the use of a structured EMR checklist. So I'm going to introduce you to the project site in a bit, but I wanted to give you some background and an organizational assessment that I completed prior to kind of starting to develop this process. This was a SWOT analysis where I looked at the strengths, weaknesses, opportunities, and threats to change at this project site. This was a survey that was sent out electronically to clinical staff, as well as key stakeholders like practice partners and owners. It was approved by my DNP project team prior to dissemination, and all of the recipients were told that it was anonymous and voluntary. And here are some of the highlights that I named from that assessment. And those that are highlighted in yellow are key ones that I want to just briefly discuss with you. So strengths, it was clear that the project site provides excellent medical care and offers support to postpartum individuals. And what that told me, and was supported by anecdotal evidence, is that this project site does postpartum care really well. The staff feel like they do it well, the patients feel supported. And so my question is it being documented and is it being captured? A weakness was that there's not a standardized process for postpartum care documentation. I want to be clear, there is a postpartum template used at this site, but there is not an inclusion or a standardized process for those 8 essential components. So an opportunity is to standardize that and include those components in that template through a checklist. And then threats to this kind of change is that at the time of the survey, only 14.29% of participants were aware of what those 8 essential components were. In anticipation of the project, there are some facilitators and barriers that I am accounting for. One of the biggest facilitators that I feel is leadership support. Leadership identified this as a need prior to the DNP student entering into the conversation. So they have investment and buy-in. And one of the wonderful and unique things about this project site is that leadership, practice owners, are active practitioners in the practice, which means they're going to be intersecting with this data in real time, and they are going to be the ones utilizing this intervention. There's engagement from staff. There's a culture of effective communication, which was clear in my strengths analysis. There's access to resources already available within the EMR. However, there are some barriers that I want to be aware of and potentially have plans to address. It's important to name that this is a relatively new practice. They're in their 2nd or 3rd year of active care. And so to kind of mitigate that or just be aware of that, my plan as the DNP student is to lean into the culture of change that already exists. As a new practice, they're used to changes and they're used to adaptation. And in congruency with their ability to have effective communication, that's how I try to plan to work with the new practice. Adjustment to change in workflow is just a reality that always exists with change. And so to support staff in this change, as you'll see in my timeline, I plan to have staff feedback and staff input into the change so that there's continued buy-in. And while a small sample size probably helps me with feasibility in my project, generalizability in the future might be in question, but I'm not going to account for that. I want to introduce to you both a theoretical and a conceptual framework that I am going to be applying to my project. The first one will be Deming's Plan, Do, Study, Act model. And I'm very aware that most of you, if not all of you, are familiar with this model. But just to walk you through it, the Plan, Do, Study, Act, or PDSA involves 4 different phases. The planning phase, where you plan the change, you make a plan for data collection, you make a prediction, and then you recruit members of your team. The do phase involves carrying out that plan. And during that time, you're collecting observations and you're collecting problems. During the study phase, you're analyzing that data, looking at that feedback, and then adapting or making a change as needed, and then acting on that adaptation, and the cycle kind of starts over. So how I will be practically applying this to my project is that you'll see on the timeline, I plan to have 5 2-week PDSA cycles. So just to give you a brief introduction of what that will look like, my goal in the plan phase is to improve the quality of postpartum care. I've said that many times now. And I'm going to introduce to you in a bit a chart audit tool that I developed. to collect the data. And my prediction is going to be that the EMR checklist is going to improve or enhance the quality of postpartum care. During the due phase, all providers and staff at the clinic at every postpartum visit will be implementing this EMR checklist. And I have scheduled out for staff meetings during these 2 weeks to be able to collect observations or problems or concerns. And I'm going to document that as a summative narrative. Then I'm going to study. I'm going to look at nominal descriptive statistics, looking at percentages of completion as well as frequency rates. And I have the data pre-intervention, and I'm going to compare it mid-intervention and compare that to the guiding prediction. If a modification is needed, I will make it. I want to be really clear that I can't totally anticipate what that adaptation or change is going to need to be. But in discussion with my practice mentor, some potential ideas could be creating staff reminders, building the checklist into prep, adding additional educational resources. And during these cycles, I will be using the Institute for Healthcare Improvement's PDSA worksheet to kind of document my findings. The conceptual framework that I will be utilizing is Dorothea Orum's self-care deficit theory. And why this was chosen is because the literature supports the use of this theory in improving health outcomes for the postpartum client. But to give you an overview of the theory, this theory basically says clients can promote self-care for themselves. However, self-care deficits can occur when that capacity is met with pressures that impact this capacity and they're not able to do that self-care. And during vulnerable periods, when someone is more likely to experience a self-care deficit, nurses and the healthcare team can intervene and offer support and intervention. And there's 3 core concepts that are going to be applied to the project, including universal self-care requisites, which is essentially self-care that's essential to all humans, and they include nutrition and safety and rest. Developmental self-care requisites, which recognize that self-care deficits occur during transitions and life stages. And then health requisites is when a client experiences a specific condition that puts them more likely to have a self-care deficit. So, how Dorothea Orum's self-care deficit theory is going to be applied to my project is the overarching understanding that postpartum is probably one of the most vulnerable times a person has, and self-care deficits can occur. And the intervention of this project, a structured EMR checklist, is screening for those deficits. You're looking for postpartum depression, healthy lifestyle, safety concerns. So universal self-care requisites are applied through those components. Developmental self-care requisites is applied because no matter how many times a person has been a parent, adding a new child is a transition. And so we recognize that a self-care deficit can occur and the need for this screening during that period. And then healthcare requisites, that's when specific conditions occur like postpartum depression or gestational diabetes and screening for that potential deficit. So, to introduce to you to the project setting, the setting is going to take place in a low-risk prenatal and primary care clinic. And I hope that kind of highlighted for you how this is a bit unique. It's not just a prenatal clinic, and it's not just a family med clinic. So it will be family nurse practitioners, licensed practical midwives, certified nurse midwives utilizing this checklist. And one of the wonderful things about this site is that all clients receive at least 1, most of the time 2, sometimes 3 or 4 or 5 or 6 postpartum visits. And as I alluded to, there's a pre-developed space for this checklist to exist in. So I wanted to see, is this even a need, right? Do we need to do this project? Because as I said, everything tells us that the care at this project site is being done and being done well. So I did a chart audit and I collected data from January 3rd to October 20th of 2025 and audited a total of 179 charts. And I want to kind of highlight some things for you. The graph that you see here is the percentage of completion of the 8 individual components. So if you take a look at breastfeeding evaluation and education, postpartum depression screening, and family planning counseling, the project site is doing this quite well. And by quite well, I mean greater than an 85% completion rate. There was no surprise there. However, what I want to tell you as the DNP student is that while I was able to obtain this data, it was documented in different areas by providers. And so when I ran a quality reimbursement report through the EMR, it wasn't calculated or collected. So again, although they're doing this work and doing it really well, it's not getting captured in a systematic way. Tobacco use screening was completed at 26%. Again, this was being done during pregnancy. It's just somehow there's a gap in it getting done in postpartum. Same with healthy lifestyle and behavioral advice. Gestational diabetes was 14%. And the one I want to highlight for you is that there's no current screening process at the project site for IPV. And this is the frequency rates. So for the participants of this project, I want to be really clear. The participants are not postpartum clients, but rather the charts. And so they're going to be selected by having all postpartum visits during the project timeframe. My inclusion criteria are visits that occur within the 12 weeks after a client gives birth. The visit happens in the time frame, and the chart is accessible to me as the DNP student. Right now, the anticipated number is about 17 postpartum visits per month, which I'm being told is probably increasing. But based on this number, during the project, that would be 68 charts with 8 different components, leading to 544 individual pieces of data. So, the intervention. I've introduced to you all the concept of a structured EMR checklist that is developed, but still going through the approval process with the site. And it will include the inclusion of those 8 essential components. As I mentioned, there's no current screening process for IPV at this project site. And so research led me to a tool called the HARK screening tool. This stands for Humiliation, Afraid, Rape, Kick Screening Tool. This is a 4-question, either self-administered or the clinical staff ask this of the patient, and they're scored yes or no, and a yes is considered a positive screening. Why this screening was chosen, why the HARK tool was chosen, was because it's approved by the U.S. Preventative Service Task Force for screening for IPV, as well as approved for MIPS by having that included for reimbursement criteria. Now, it did not feel ethical to me to screen for IPV and then not provide any follow-up or education. So one of the educational resources that I'm currently developing is evidence-based handouts. And the evidence supports repeated visits, safety planning, and referrals. And so I'm developing those resources for staff and patients if someone would screen positive for IPV, because we don't want to screen and not have a follow-up intervention. So this is an example of my chart audit tool, how I have collected data for pre-intervention and how I will be collecting data. This was approved by my DNP project committee, and it includes the 8 different components. And then I classify it as Y, included or documented, and no. And then I run formulas to calculate percentage of completion and frequency rates. So the measured outcomes are going to be percentages and frequency rates of the 8 essential components. Doing this pre-intervention, which has already been done, mid-intervention during my 5 PDSA cycles, and post-intervention. And we're going to consider quality improvement if there's an increase in these rates. And after the project is done, post-intervention, I plan on completing a chi-square test to determine if the change was statistically significant. So fortunately, a financial plan and institutional review board approval is not indicated for this project, but other resources that I anticipate needing is further EMR training, as well as quality improvement training, resource development, as I mentioned, potentially some education for staff, and then of course, time. Here is an example of my timeline. I'm not going to walk you through this all in detail. Again, you'll have access to these slides, but I just wanted to highlight for you that I have the PDSA cycles mapped out along with meetings with staff and chart audits. And again, the project is going to end on April 24th. So this is fictitious data, but this is how it will look when the data is collected. This is an example of the chart audit tool. Again, Y for if it was documented, N for no. And then to analyze that data, again, it's the percentage and frequency change percentage for each component and using that chi-square test to determine if it was statistically significant. My categories will be documented versus undocumented, and my proportions are pre-intervention and post-intervention. And this is how I plan to kind of report the change percentages in the paper. So to end, my hope for a sustainability plan is that this will become an integrated part of the workflow of postpartum care at the project site. My hope is that the clinic site manager will take ownership of this checklist and that it will remain embedded in workflow. There are going to be chart audits that naturally occur because this is what's needing to submit for quality reimbursement. And the provider team at the project site will be responsible in looking at those guidelines, such as ACOG or MIPS, to make sure that the components of the checklist stay relevant. And then also always needing included buy-in from stakeholders, leadership, practice partners, etc. So here is a list of my references. And I just wanted to give a wholehearted thank you to some people really briefly, to my DNP project team, my faculty lead, Dr. Rittenhouse, my peer, Amy Steyer, my project mentor, Dr. Eleanor Colmenares, my course professor, Dr. Beth Miller, the program co-directors, Dr. Yoder and Dr. Cash, the proposal approval committee, and then thank you to all of you for attending this presentation.
Thank you, Hannah, that wonderful proposal. This is our opportunity now to ask any questions that you might have, clarification, something you'd like to know a little bit more about. Please feel free to unmute yourself and ask your question, or if you prefer to put it in the chat, I will read the chat.
I have a quick question. Hannah, for the screening tool that you're going to use, I've already forgotten the name of it. It starts with an H. Hark.
Mm-hmm.
Maybe you said it and I missed it, but can you just describe, I'm thinking about a woman who may be experiencing IPV and being in a visit with someone else in the room besides just herself and the practitioner. So just briefly touch on how you're going to protect clients in that particular screening situation.
Yeah, thank you for asking that. That's a really important thing that needs to be factored into. So one of the things about the project site is that their electronic medical record is with their patient portal. And so patients have electronic access to all the screenings. So this screening can be done before the visit, and the provider can have access to that before the client even enters the space. But it can also be administered via paper if the person or partner was in the waiting room or something like that. So we would have multiple avenues of being able to administer this. Thank you.
Wonderful.
Go ahead, Dan.
Yeah, great presentation. It's exciting to see how your project's progressing. Just a clarifying question. You're doing these five PDSA cycles. So are you doing something, are you adding something planned into each new cycle, or is the second cycle looking at what you tweak based on the data from the first cycle?
Correct.
Does that make sense?
Yeah, thank you for asking that. So my idea is, I mean, I would love not to have to make a lot of adaptations, but based on the data, if there's like one particular component that's not having an increase in rates, maybe identifying like a small intervention or tweak that we could implement to be able to get those rates up at the next cycle. So I am hoping that during that study phase of the PDSA cycles, that will inform the next cycle.
Excellent job, Hannah. I'm so happy with this project. I think it's a great one. Just a clarifying question. You alluded to some resources that already exist in your system for patient education and information. Do you have you feel confident in the areas outside the additional tool that you're going to implement for healthy lifestyle, cigarette cessation, et cetera, to meet those other 8 components?
Yeah, thank you for asking that. So one of the things that I didn't name is that I anticipate and I'm working on making a handout about healthy lifestyle and immunization follow-up. I feel very confident in the project site's assessment of immunization as well as the education on all of these things. I just want to provide additional handouts, and I'm developing that based off of guidelines and evidence, of course.
Thank you.
Thank you.
Any other
Good job, Hannah.
questions?
That was amazing. Oh, go ahead.
No, I was just asking if there were any other questions.
My question is, one, I think it's brilliant that you're including the resources if the IBP screening is positive to be a forward thinker in that movement. But I'm wondering how this is going to affect their MIPS score reimbursement with this project. Is that something maybe the practice site is going to evaluate, or is that something you thought about including?
It won't be included in my project necessarily, but it will be evaluated. Yes. And that's kind of a lot of the influence behind this project.
Right. Well, if there are no final questions, let's give Hannah another round of applause, virtual applause. And we again thank each of you for being here and hearing Hannah's proposal defense. And at this time, we invite you to go on about your day, and we will keep Dr. Yoder and Dr. Rittenhouse, and I'll stay on here to have further conversation with Hannah. Thank you again.
Thank you.
Hit the stop record there, Jewel, for me.